Thanks again if you've just joined us. This is the special webinar on accessibility guidance in healthcare settings. And the webpage where you registered and where the recording of today's webinar will be in a few days is listed here and will be shown throughout the webinar and will be put into the chat as well. earthquakecountry.org/event/health-aug22, healthcare August 22, 2022. So we're still admitting some people into the room, and my name is Mark Benthian. I'm the Executive Director for Earthquake Country Alliance. And little overview, we are a statewide organization that we encourage all of you, if you aren't currently a member, to join. And we know many of you may be joining us from other states. If you are interested in earthquake information and resources for this topic and others, you're welcome, even if you're in another state, to join the California-based Earthquake Country Alliance. And you can see the address there, earthquakecountry.org/join. We have sector-based committees, including our healthcare committee and our accessibility committee, which are represented today on this webinar. We also have regional alliances throughout California. We're funded by the California Office of Emergency Services using federal funding from FEMA. They were managed out of the University of Southern California. The federal funding we get is part of the National Earthquake Hazards Reduction Program. And it's a process that FEMA provides this funding to states with earthquake hazards. There's an application process, and Cal OES, as part of their program that they propose, provides funding to Earthquake Country Alliance for our earthquake education, outreach, and mitigation activities. Our statewide activities include our messaging and in our web pages, both in English and Spanish, earthquakecountry.org and terremotos.org. We provide support for California Tsunami Preparedness Week through a website called Tsunami Zone, which also supports other regions. And of course, the Shakeout, our California started Shakeout, Earthquake Country Alliance led it back in 2008. And of course, now is a annual event that's spread across the country and around the world. You can find out about more of our events at earthquakecountry.org/calendar. These are our committees. As I mentioned, 2 committees represented today, our accessibility and healthcare committee, but there are several others for these different sectors. And if you're interested in any of these, you go to earthquakecountry.org/committees to learn more. We have outreach bureaus too. And if you're in California and would like a presenter or an information table at your event, please go to earthquakecountry.org/events to learn how to complete a form that will give us the information that we need in order to find someone to come to be at your event. Key messaging of Earthquake Country Alliance is organized along the 7 steps to earthquake safety. Just want to point these out to you, make sure you're aware that you can refer people to these both in English and Spanish, a main page at earthquakecountry.org/7steps and terremotos.org/dialysis as a somewhat one-stop shop for earthquake, what to do to be prepared to survive and recover from earthquakes, what to do before, during, and after, with a lot of this information that maybe talked about today and other details for each step. We also have updated information and new documents in 15 languages, 13 documents now in each of these languages, including special web pages for each language with just the documents for that language. And so the main place to start there is at earthquakecountry.org/languages. And just a basic message to make sure you're aware of our accessibility guidance for what to do during an earthquake. You can go to earthquakecountry.org/accessibility. You'll also find that on step 5, which is the step for what to do during an earthquake. And as you can see here, we've adapted the general message of drop, cover, hold on to people who might use a cane, a walker, or a wheelchair, and other situations you might be in whether you're in bed, whether you are outdoors or driving a car, etc. All of that can be found at earthquakecountry.org/step5. Right now, I'd like to turn over today's meeting to our host, Sue Fisher, who's the co-chair of ECA's Accessibility Committee, a certified emergency manager, former emergency manager for California State University, Fullerton. Sue, welcome and thank you for being with us.
Thank you, and a great afternoon to everyone. I'm very excited about this seminar. It's always very exciting for me, though, to be able to emphasize the topic of disability access and functional needs as we do a lot of our planning and exercising. So I think that this will be a seminar filled with lots of really great information, and we've got three really high quality people that really understand this topic and will be able to lead us through some really terrific ideas today. So welcome everyone who's participating. And now I'll introduce our first speaker for today. I suspect that he is someone who is probably well known to an awful lot of you. For those of you who have heard Vance speak before, we're in a great group of people, and I'm very pleased to be able to hear Vance again today. So Vance Taylor is the Chief of Office and Access and Functional Needs out of the California Governor's Office of Emergency Services. And his topic today is an introduction to access and functional needs. So Vance, take it away.
Excellent. Thanks so much. I appreciate it. Yeah, if we can just start on the slide 1 here. So let's go next slide. Excellent. Great. Thank you. So hey, I'm Vance Taylor, and I'm glad to be here. I appreciate everybody being on. I'm a quick one to say that anytime you're doing these online events, but you've got options, right? You're online, there's a lot of content that you could be taking right now, but you chose to be here. So thank you for letting us win the battle over Netflix and Hulu and Apple TV and your other options. I want to jump in and I'll start because with definitions, because I think that as we talk about things like disabilities, as we talk about things like access and functional needs, it's really important that we're on the same page. Because I tend to think we kind of know what that is, but we don't always know exactly what that is. And so it's just kind of easier to start with the definition. So when we're talking about disability, know that these are the 3 bullets. The first, of course, I think is the one that people are most familiar with, which we're talking about something that substantially limits one or more major life activity. But when we say disability, that's not synonymous with access and functional need. If you go to the next slide, what you'll see is that when we're talking about access and functional needs, it's really an umbrella. And within that umbrella or under that umbrella, you have, yes, people with developmental, intellectual, or physical disabilities, but you've also got people with chronic conditions and injuries, right? You've also got people that English isn't their first language. And as you go down the list, you see people in institutionalized settings, you see people that are older adults, children, women in late stages of pregnancy, people that are experiencing homelessness or transportation disadvantage or economically disadvantaged. And so as we begin to think about who falls under that umbrella in a state with 40 million people, we're talking about an immense number of individuals. And the reason why this matters, like why are we defining this? Why do we spend so much time talking about this? Why am I preaching, teaching, and promoting this concept of integration? It's because the system that we have in place right now, if we go to the next slide, for addressing the way that we plan, prepare, respond, and recover hasn't always been whole. Right? What we've been working to do is to make the system whole. we've been working to take an emergency management system that was ultimately developed by individuals without lived experience in the areas of access and functional needs, who did the best they could, who were well-intentioned, but who lacked a fundamental perspective that ultimately created gaps in the way we're able to meet the needs of the whole community. And so it's our role, it's our mission, it's our charge to integrate emergency management by adding the access and functions perspective so we can make the system whole. Talking about that perspective, if we go to the next slide, it was really Hurricane Katrina that brought this discussion to a national level. And that's because we saw during Katrina on live TV that 70% of everyone who perished had an access or a functional need. And the disparities associated with that disaster weren't limited to large-scale events. In fact, what we found was that every disaster, regardless of size, type, scope, scale, or geography, had one thing in common. There was one factor we saw throughout, and that was that there was a disproportionate impact on the people who have access and functional needs. So California, recognizing this, leaned forward and created the Office of Access and Functional Needs. The governor appointed a senior level executive that really is charged to run the office with a twofold mission. One is to identify what are the needs that all Californians have before, during, and after disasters. And once we identify those needs, how do we work collaboratively with our partners to ensure that we're integrating those needs throughout every facet of the emergency management process? If we go to the next slide, you'll see that emergency management is a partnership. That this mission is much too large for any one group, organization, government entity, hospital, community-based organization, but to do on their own. And there are some emergency managers that knew and understood, okay, there are things out there that we just don't know. And then there were others, right, that know there are things they don't know, and they're waiting for someone to integrate them. But ultimately, what that comes down to is you and I, right? It's looking at where are the gaps, what are the gaps, and then working in an innovative form and fashion together to be able to fill those. I spoke, there was an earthquake conference years ago, probably 4 years ago, 5 years ago. And after my presentation, a gentleman named Steve Storbachen came up and said, hey, I've got an idea. I'm with the Pomona Valley Medical Center. I've got this idea that when there's disasters, let's say an earthquake, and surrounding communities are impacted, there are going to be people who come to the hospital, not even necessarily because they're injured, but because they're going to need oxygen or dialysis or other services and resources. And he said, I don't know that we're ready to be able to meet that need because I don't know that we truly understand what the risk landscape is. You know, when we're doing possible vulnerability assessments, we're not really factoring access and functional needs into those assessments in a way that enables us to be confident about our approach moving forward to serve the communities and the areas the hospitals exist. What do we do about it? You know, and Steve, being, for all of you know, I'm very innovative and very determined. Said, you know, we're going to make this happen, and so we pulled the team together, and the product, right, what came out of that process is ultimately what's going to be outlined for you today. And to see the evolution of where we started with that initial discussion to where we are today, and to see the way that it's being picked up throughout the healthcare settings, and to see where it's going is very exciting. For me, I recognize that, like all things, there's an evolution, that we're not there yet, right? Quote, there yet, but that we're working our way in that direction. And so I'm going to turn it over to Steve. He's going to talk about a bit more about this process, this project, what it is, and take it from there. But I just want you to know I appreciate you being here, and thank you.
Thank you, Vance. That was great. Sharon, she is going to be fielding the questions to the chat. Do we have some questions for Vance, or should we move on and let the questions go to the end? What do we have, Sharon?
We do not have any questions yet, but please, if you do have questions, put them in the chat and we'll be sure to get them answered for you.
Yeah, if you've got easy questions, for sure, send them my way. And if they're really tough, just wait till Steve comes on.
You beat me. You beat me, Vance. You beat me.
Well, we'll have some tough ones for both of you guys when we get there. So I guess we'll move to the next slide then, please. Okay, so our next two speakers, let me get my notes so I get these titles correct, because it's a pretty impressive trio that we have today. Following Vance is Steve Storbachen. He is the Director of Emergency Preparedness and Environment of Care Compliance at Pomona Valley Hospital Health Center. And with him also is, hopefully, and he will be able to make it today, is Kevin Masinski. And Kevin is the project manager of support services also at Pomona Valley Hospital Health Center. And so with that, I'm going to turn it back over to Steve, and he's going to start the presentation. Take it away, Steve.
Thank you very much, Sue, and thank you, Vance. Go ahead and go to the next slide, please. Go ahead, next one. So I just want to start by saying that this has been quite a journey for myself and Vance, and hopefully Kevin will be able to join us today. And looking at how do we incorporate access and functional needs planning into a healthcare setting? How do you do that? So one of the things when I met Vance at the earthquake conference is I told him that I had an idea of how we could create access and functional needs disaster risk assessment tool, which would allow healthcare providers to do a risk assessment, see what the greatest risks are. So we formed a team. Vance was very interested. In fact, he had said that one of the areas that he wanted to have inroads into was the healthcare sector. So we created a team, we met, and one of the first things we had to do was come up of how we would look at the access and functional needs community. And so we had a lot of discussion about that because there's a lot of terms that aren't being used anymore, like handicapped. There's terms, older terms, I think most people now have phased them out, of disabled individuals, special needs, vulnerable populations. And generally, we call this now access and functional needs. So in looking at these different communities, we also needed to come up with a common terminology. And one of the things that we found out is that there's a lot of different groupings and listings that were out there. And so we kind of decided to use what Cal OES and Vance and his team were using. Go ahead and go to the next slide. And there's also some new terminology, CMIS being one, which I really like and a lot of people are using now. And the reason for that is it defines the members who may need to have additional needs during or after an incident for access and functional areas, including not limited to communication, maintaining health, independence, support, safety, and transportation. And thank you to June for this new terminology. But this is really what we wanted to kind of look at in doing our risk assessment tool. And then what we wanted to do with that tool once we completed that was to be able to have some way of assisting people to do planning. So next slide. So in looking at the access and functional needs community, the Census Bureau determined about 26% of the American population has a registered disability. FEMA estimates that it's somewhere in the 30 to 40%. In doing research on this and a lot of things that Kevin has looked at, depending on where you're at, it could be as high as 50%. So it tells you that there's an incredibly extensive and diverse community out there who have some type of limitations or restrictions that they're going to need help with in regards to emergency response and planning. And there's a lot of different communities out there. Next. So like Vance said, we met at the earthquake conference. We had a discussion about looking at emergency planning. We got together a really great team. One of them was somebody who worked for me, Kevin, who's a brilliant guy. And so we sat down and we developed the AFN Disaster Risk Assessment tool and program. Next. And then as part of that, when we developed that and looked at that specifically for Pomona Valley Hospital, one of the things we wanted to do was develop a guidebook, because now that you know what your higher risks are, like for Pomona Valley, one of the things that was kind of surprising to me is what a large population of dialysis patients that we had. I knew there was a lot. I didn't know it was as large as it was. So we wanted to create a guidebook, which would be a single resource tool that people could use, that when they've used the risk assessment tool, or even without the tool, they could reach out to the communities that they know they need to do planning with and have an easy way of being able to do that. So we're very fortunate that we're able to get a grant from the California Community Foundation to improve disaster preparedness and resiliency in Los Angeles County. And we formed a team of Connie Rango, Julian, and Ning Tao to look at the resources that are available out there in doing planning with the access and functional needs community. Next. So you'll have to excuse the background overhead pages. Thank you. So the guidebook, it lists some access and functional needs community and agencies. And what we decided to do is we would list the access and functional needs grouping using the access and functional needs communities that we based the AFN DRA on, and that we would list them in a national, state, and then local level, so that the guidebook would have a much broader access and availability to the whole healthcare community in the United States. So we were able to do that through doing research and using the disaster risk assessment tool. And also this allows you to incorporate your planning into your emergency operations plan, and then to develop your policy procedures in your planning. Next. So some of the advantages, it kind of creates a common grouping. We have over 1,000 websites listed. We screen the websites to the very best of our ability to include what we consider to be best practice being first listed, and then in each of the different communities. So when you go to the national community, when I show the guidebook, when you see the national, the first one listed is the one that we thought that had the best and most current information. And then we got second, third, fourth, fifth, and down. And then the same with state, and then same with local. Now, the local listings are all local LA County, local Pomona, but most of the information that's available, if you look at it, is pretty universal. Okay, we listed it community by community. We gave a brief description, and the majority of the information that we were able to find was national. And it was amazing the volume of information that was available out there. Next. So just a little disclaimer that basically we're doing this to the very best of our ability. We had to make some judgments of what we thought was best. Some people might not agree. They might think something else is better, but this is the very best. Also, this is a snapshot. The guidebook was finished on June 16th of this year, and I'm working right now of trying to get it posted on a couple of state web pages, so everybody will have access to this. But like I said, we made sure that all the web links in the guidebook are valid and contain the information they said they contain. But again, it's a snapshot of town, and it's our very best guess. Next. And then next. Also, these websites, they will change with time. The funding that we got for the guidebook, that was a one-time funding. Hopefully in the future, I'll be able to get funding to update. But like I said, this is kind of a snapshot. Okay, next slide. We used a lot of different information in our guidance, and I know Vance covered part of this. We're following CMS and healthcare guidance. I know if city or county did the guidebook, they'd probably look at it a little bit differently because they have different titles and regulations that they have to comply with. Like university and colleges would probably look at this a little differently. So the funding that we got was for healthcare to help healthcare. So you'll see that when you go through the guidebook, that's kind of the focus. Most of the references that are in the guidebook are universal, though. I think everybody could have value and use out of the guidebook, but we just need to kind of state that depending on what your framework is from, if you're in healthcare, you'll see that this kind of follows a healthcare format. Next. So there's three major categories in AFN communities that we determined. One is medical issues, chronic medical condition, disabilities and disorders, physical, psychological, and intellectual, dependence on medication, medical equipment or consumable medical supplies or services, significant injury or illness and predispositions, pregnancies, especially high risk, age-related requirements and limitations, almost all minors and older adults, and cultural, racial, ethnic, religious, and socioeconomic needs, which is a very diverse community. We actually left the research in this community as last because we knew that we'd be overwhelmed with the volume of information, but there's some very good information out there, and a lot of this will go across many different types of cultures or ethnicities. Next. First is medical issues. What I'm going to do is I'm going to walk you through the communities. I'm going to show you some examples of the guidebook. It's very extensive, but I just want to kind of share with you the research and what's going to be available. So in looking at the AFN communities of physical disorders, it's about 16% of the population. 7% have difficulty walking or climbing stairs, about 9% blind or vision impaired, 5% dexterity, deaf, hard of hearing, 15%, only about a third of those wear hearing aids, speech and lingual disabilities, 2%, and sensory impairments and sensory processing disorders. Next. So this is what the guidebook looks like. As you can see, we listed the national federal resources that were available for these areas. This is for mobility and ambulatory impairment. Next. And then we go to state level resources. Next. Okay, and disability and blind and visually impaired. We start with the national, what we consider to be the best practice is the top 3. Next. And then dexterity impaired, federal and state resources. Next. Deaf or hard of hearing community. Just a note on this, I know Vance could probably talk a couple hours on this in regards to some of the issues they had in regards to the evacuations with the wildfires in Northern California. What a lot of the planning with the deaf community that they've done since then have shown that there are other tools that we have to use to be able to communicate with the deaf community and being inclusive in them, that they aren't part of some of the regular communication systems that people get information from. I know LA County is also looking at handing out radios that have the ability to have devices attached to them so they can assist with the visually impaired and the deaf and hard of hearing. So that's one of the areas that we need to work on as a community. This was also very challenging, and pretty much every evacuation that's been done across the United States in the last 20 years. Next slide. Okay, neurological disorders, state and national resources. There's epilepsy, disaster preparedness of Alzheimer's. Next. Speech, voice, and lingual impairments. Okay, next slide. Smell and taste impairments. So you can see this is really diverse and very, very comprehensive. Next slide. The next community is individual with psychological disorders. It's about 18% of the population. About 4% is severe. There's anxiety disorders, mood disorders, depression, personality disorders, dementia, eating disorders, addictions, and psychotic disorders. Next slide. So psychological disorders, there's a lot of available resources out there. There's also a lot of community centers that you can reach out to and do some planning with. I know locally, we've done some planning with a local mental health organization. Next. Depression and mood disorders, state and federal links. Next slide. Personality disorders and dementia. There's a lot of resources available out there. I know if you look at a lot of these disorders, and we'll be talking about this throughout the presentation, that most of us are in one or another community. That's why FEMA's come out with some studies and findings that as many as 50% of the people are in some sort of access of functional needs community. Next slide. Individuals with intellectual and developmental disabilities, 2% of the population. And there's many different disorders. One of the things that we've worked with is autism. One of the hospitals I worked at had a very large autism daycare center very close to the hospital. And we actually did an exercise, and we had some people with who were autism experts come in. And one of the things that was they brought up immediately is how much stimulus there is within the emergency room. I don't know if any of you have been in an emergency room, hopefully not. But if you're in an emergency room, I'm in them every day. There's a lot of activity going on. There's a lot of noises. There's a lot of, it's very bright. There's a lot of activity. There's a lot of different odors and smells that go on. So the first thing that they brought up, that for the delayed and minor treatment patients, to try to get them out of the ER into another area where you can control the environment a little bit more and try to tone it down. Because with the autism spectrum, that's gonna actually set them off and create a lot of anxiety. So we actually had a discussion into how we would do that and to assist with that if we had, like, say, a bus crash with a busload of autistic students from the school, and how we would pull resources in to help with that. Okay, next slide. So it's intellectual and developmental disabilities, national resources that are available out there to do planning. Next. And some state level resources. I would also offer for you to reach out to your local community after you do the risk assessment, or even if you don't and you're aware of that community resources out there, and work with those communities and plan with them so that your staff can be aware of what's going on in your community and what your potential higher risks are. Next. State and additional resources. Next. Individuals with chronic medical conditions. About 60% of adults have a chronic medical condition, 40% have 2 or more. These are conditions that typically are staying with you more than a year and need ongoing medical attention. Oftentimes these aren't people that are in the hospital, but are in and out of the hospital. These are often caused by life choices, and these can be chronic. Like I said, part of the problem is it's oftentimes that it's not just one. You're not just in one community, but these are also maintained by being in other potential communities, like being on O2. So therefore you're dependent on electricity. You need ongoing medications. You need ongoing home care. So it's very cross-sectional. It's very complex. Next. Chronic lung and respiratory disease. One of the things that we had to deal with that came up with COVID was that people who were O2 dependent and the ability to get resources out to people with the surge of COVID patients, and it created a lot higher population of people who became long-term O2 dependent, especially if you're unable to get oxygen concentrators and you're dependent on e-cylinders, especially early on in COVID. That became a very significant problem. Also, hospitals were heavily impacted by the O2 problem because of the volume of O2 that most of us were having to go to for the high flow rate O2 patients, which was most of your long-term COVID patients. There was actually several hospitals within LA County that had to close to incoming patients. They couldn't accept any more patients, mainly because they couldn't provide the O2 volume that was needed. They were able to adjust it to it as a system, but that was a real problem early on in just getting oxygen concentrators and those kind of devices available for people. And unfortunately, that's one of the long-term effects of COVID with some people is long-term being O2 dependent, unfortunately. Next. Heart disease and stroke and being dependent on medications and other long-term effects. Next. Dialysis, renal disease. This is an area that when we first did our risk assessment, Kevin and I, hi Kevin, glad you could join us.
Thank you, Steve.
That one of the areas that we looked at was and noticed that it was a very high risk was dialysis patients. So we've tried to do a lot of planning with our local dialysis agencies, especially the ones that aren't affiliated with the hospital. And I'll cover that a little bit more at the end. But I could tell you that dialysis patients and people who are dependent on dialysis, including, we'll talk about a little bit, people who are diabetic and dependent on diabetes medication, that these are conditions that if there isn't good planning with this community, that those patients become critical very, very quickly. And I've been involved with some very long-term discussions, serious discussions about that, because the volume of people in these communities is very, very, very large. Katrina, one of the impacts of Katrina long-term was that those communities that weren't able to be dialysized and weren't able to get their diabetes medications ended up being the patients that were shipped to Houston, for example, as critical patients with just a week or a week and a half later after the event. This also included in Houston, they had a winter storm that shut down the city and a lot of their outpatient services. Well, one of the bigger impacts that they had as a result of this was the dialysis patients and the community out there that couldn't get their regular medications. Next slide. So type 1 and type 2 diabetes. And oftentimes people in these communities, they also have other health maintenance issues that they need to maintain with medication. Unfortunately, with diabetes, that's one of the outcomes. Next. One of the follow-ups to Katrina, one of the reports I was reading on that was that there was a lot of patients who had diabetes who were walking around in the water where New Orleans were 2 and 3 days after the hurricane and weren't on their medications. So that made them more susceptible to infections. And a lot of these patients ended up having secondary infections and very serious infections that were in part due to the fact that they couldn't maintain their medication. Next. Obesity, national and state resources. Next. Victims of chronic abuse, violence, or neglect. There's some very good resources out there regards to planning. I know also the other outcome, unfortunately, in some of these larger, wide-scale natural disasters that happen, that as communities are cut off and don't have access to normal systems in healthcare, that a lot of times these types of incidents increase. Next. Some local resources. Next slide. And there's specialty nutrition needs and large-scale disasters, people who are unable who have allergic reactions to different types of food and need to be on special diets, need to be make sure that they do very specific individual planning to be able to maintain what they need. After the large-scale disaster, or if you're involved in a large-scale disaster, it may be very hard for you to meet those needs. Some of these are very serious. I know of an individual who's pretty much allergic to everything. It's not an issue of what she's allergic to. It's the very few things that she isn't allergic to. So it could be very restrictive. Next. Other chronic diseases, like I said, that's some of these are very much long-term, cross-sectional, and kind of compound on each other. Next. Individuals with pharmacological or medical supply equipment deficiencies. It's about 45% of Americans take one medicine, 70% take three. Like I said, oftentimes you'll find people, you know, who have COPD, they're on medications for that. They're also on oxygen concentrators, and they're also dependent on somebody helping and taking care of them. Durable medical equipment like hospital beds and other mobility devices. I would just like to note Dan, he's the emergency planner for the city of Sacramento. He actually had an incident in the local incident they had where they had the shooting downtown. Well, one of the local areas that they had to evacuate because of that was an assisted living house. So the law enforcement did a great job in going in and evacuating everybody. But now they had a problem where they had 40 people who needed various types of assistive devices to be able to maintain normal lifestyles. So fortunately, Dan had a mutual aid agreement with some local suppliers, and he was able to call those. But oftentimes these kind of things are overlooked in our planning. And consumable medical supplies too can become a problem, especially when they are no longer readily available. Next. So pharmacological dependencies, some of the resources, state and low federal resources. Next. 3 or more types of medications, some information on emergency planning and what you can do. I know a lot of suppliers have gotten much better in giving people longer term supplies. There's also some techniques and things that you can learn if you go through these resources of how you could develop that or ask for help with that. Next. Equipment dependencies, and a lot of these are power dependent too. There's different programs out there. Also too, if you are dependent on electrical supply, hopefully you are, you've gotten the message, or we're making sure that the message is out there to people to make sure they inform their local power suppliers so they can be put on a list as somebody who needs assistance in this area. Next. Consumable medical supplies, federal, state, and local resources. Next. Individuals with medical service dependencies. basically being dependent on somebody helping them with their care. Could be formal or informal. They could have service animal dependencies, home health service dependencies, hospice. Institutionalized, there's a lot of independent living facilities now out within our communities. Long-term care, acute dependent, or electrical power dependent, or refrigeration. Next. These are some of the resources that are available with that. Hopefully, those communities, I think, have gotten the message in that. I think that one of the areas that we've done much better job with is especially our long-term care skilled nursing facilities. There's actually requirements now for planning in regards to how you would evacuate or what you do with your facilities. Next. Life and caregiver. I can't even tell you how many disaster exercises or drills I've done in talking to people about being at the hospital for a long time in response to a disaster, of how many people haven't thought about what are they going to do with the animals that they have, or mom and dad, sister, brother that they provide care to on a regular basis. This can put some very, very demanding put you in a very demanding situation if you haven't done pre-planning with that. And these are some of the resources that can help you with that. Next. Most of us now have done a lot better planning in regards to receiving animals, service animals in your hospitals. You know, there isn't an exercise that I've done recently where this isn't a discussion. There's service animal dependence. And I think the other part of that too is that if you're unable to get home for a long time, how are your animals going to be able to be taken care of, and having a plan for that. Next. Ongoing home health care services. Home health care now have gotten really good at being able to make sure they have a good listing of their home health care customers in regards to notifying resources like fire or police in the event of a large-scale disaster. If they can't get into those communities and check on them. I know that in some of the wildfire situations, it was some of the home health agencies that were reaching out to the evacuation centers to make sure that people were notified. So I think we've done better with that, but I think there's still a lot we could do with those communities. Next. Hospice services can be very challenging. Next. Institutionalized non-medical state and local resources. Like I said, most of your, hopefully your cities have an idea of what residential facilities you have in your communities, but they can have very, very unique challenges and circumstances. Next. And long-term care dependent. There's a lot of planning that's gone on with that, especially in the last 10 to 15 years. Most of our long-term care facilities use the long-term care HICS model now, and planning. I know in LA County, there's very specific planning that they need to do in regards to how their patients are going to be taken care of. And we've made great inroads with that. And there's a lot of really great resources out there. And these are some of the resources that are available. Next. Next slide. Okay, Kevin, I think I'm going to hand it off to you. I'm getting a tickle in my voice. If you don't mind, I'm going to let you go ahead and jump in.
All right, Steve. We've got over half the presentation pending, and I see we're running a little bit lean on time here, so I'll try to spin through quickly. I believe the last section of the medical communities and so forth is those with significant injury and illness. And of course, hospitals specialize in that. We as a trauma center, of course, deal with a great deal of physical traumas as well as psychological traumas. Next, please. Next slide, please. And you can see it follows the same format. We have a large number of websites for the various types of trauma injuries. Most significant, of course, is burns. And that is the area that the hospital associations are all looking at across the country. There's only some 1,200 burn beds, high-level burn beds in the country that are usually full. And in the event of a smart bomb or dirty bomb, excuse me, there may be a significant number of burn victims that would require immediate care, radiation burns. Next, please. And again, we have psychological trauma, and it follows the same format as the originals in that it lists federal, state, and local. Next one, please. You can go ahead. Okay, and this is the last of the medical communities. Women that are pregnant, roughly 3 to 4% of the nation's women are pregnant at any given time. And those that typically will require care during an emergency or in their third trimester, and particularly those of high risk. Okay, next, please. And we have various resources available through our Google search. Okay, the next category is sort of an intermediate. That's age-related. Most of it is medical, but some of it is non-medical. Pediatrics, roughly 24% of the population is under the age of 18. All individuals, all pediatric individuals would need a parent or guardian for informed consent. And we broke it down into specific categories of preemies, neonates, infants, toddlers, children, adolescents, and then lastly, a very large category of individuals with one of 4 particular types of disorders. Okay, move on, please. And here again, we break down the federal, state, and local resources. And by far the most important to any given hospital are the local resources in a disaster. And now we have the other end of the spectrum, senior citizens. 15% of the population is 65 or older. Roughly half at 65 have one or more medical conditions. And by 80, nearly all have an AFN and at least one severe disability. We use the common rating scale, ADL and IADL. I'm sure everybody here is familiar with that. Next, please. And again, we break down the various resources, federal, state, and local. Next category, and I'll try to spin through this fairly quickly, is something that FEMA introduced roughly 20 years ago and was absorbed by healthcare largely through CMS, Centers for Medicaid and Medicaid Services, roughly 5 years ago. And it is now spreading like wildfire through the healthcare industry. That includes cultural needs, racial, ethnic needs, religious needs, language needs, immigration and refugee, which is becoming huge, and socioeconomic areas. Next, please. Race and ethnicity are often interchanged. They're often confused. Race relates to biology. It's inherited. And I believe there are 6 primary races recognized by the Census Bureau and about a dozen extremely small races. Ethnicity tends to refer to large groups of geographic origin, such as Hispanic ethnicity or Arab American ethnicity, etc. We can move on. Next, please. What is probably most important for any hospital is to identify the particular mix in their area. For example, Latinos, Hispanics represent about 18% of the nation, but in California, it's more than double that, it's 39%, and in LA County in particular, it's 50%. So again, identifying the size of the racial and ethnic groups is very, very important for planning for any hospital. Next, please. And here are the various resources. Okay, it's been through, please. Cultural needs, this is a huge category. Depending upon who you read, there are some 4,000 to 7,000 active cultures worldwide, and nearly all are represented in the United States. And again, any given hospital should be cognizant of the various cultural groups within their area and their particular needs and restrictions during a disaster. Next, please. There's all sorts of layers of culture, everything from separating the globe into East and West, or Oriental and Occidental. There's religious cultures, political cultures, language cultures. Most important, though, is national cultures. And again, there's roughly 4,000 to 7,000 cultures, national cultures throughout the country, or excuse me, throughout the planet. In particular, there's 200 in Russia, and you may be surprised there's only 56 in China. Reason being, at one time there were several hundred different cultures in China, and the government would not recognize and put an end to some 200. Similar in India, there's 36, and there are 11 emerging cultures in the United States. In addition, Indian tribes, there's over 600 Indian tribes in Canada. A common misperception is that they all share similar cultural needs and so forth, and they absolutely do not. Languages are extremely different. Belief systems, religious systems, and so forth are very different. There are 574 indigenous American Indians, and only 65 in Mexico, and a similar story there is China. When the Spanish took over Mexico a couple hundred years ago, they eliminated any of the indigenous cultural tribes that would not conform to Catholicism. 65 did, and 65 survived. Next, please. And again, it varies quite a bit depending upon the area. 11% of Americans are foreign born. 27% of Californians, more than double, are foreign born. And in LA County, a third, a little bit more than a third of the residents are foreign born. And those individuals foreign born tend to cling very closely to their to the cultural religions of their cultural traditions of their homeland. Next, please. And here we have a variety of Google websites. Okay, next. Religious needs, there's roughly 18 to 20 major religions throughout the globe, all of which are in the US. However, there are enormous variations within many of the major religions, to the point where there are 4,000 recognized branches, congregations, conventions, denominations that have distinct requirements and restrictions in a disaster. You can spin to the next, please. And again, Protestants, 46% in the United States. Yet California, it's significantly less, 32%. In LA County, it's down to 30%. And it's the one area where Catholicism exceeds Protestantism. You can see most of the other so-called major religions are very, very small nationwide. But what is of significant interest is the very bottom line, unaffiliated. Those are individuals that are quote unquote spiritual. They believe in God. However, they do not follow any particular religion. And that's becoming a very large growing area. It's tied for the second largest in California and will shortly surpass Protestantism based upon current trends. Next, please. And here we have a large variety of websites, but ultimately we want to have all 4,000 religions represented and all 7,000 cultures. Next, please. Immigrants is another potentially huge area. It's estimated that there's 45 to 50 million immigrants living in the U.S. The vast majority are legal, become naturalized citizens or permanent residents. At least 5 million have been recently arrived. That figure is a little bit outdated. That was the last number that was published by Census Bureau. What is of significant interest here is that currently the 40 to 50 million immigrants that we know of are 14% of the population. We've all seen TV with the massive immigration that's been taking place along our southern border. It's estimated by the time of the next presidential election that the number of immigrants will have doubled in the United States. We will be up over 20%. And then by the end of this decade, it's estimated, again, following current trends, that the United States will have a population of over 400 million individuals. At least 100 million will be immigrants. So the demographics of the country will change hugely. And again, the unique needs and restrictions of these immigrants are going to have a massive impact on not only the healthcare industry, but certainly municipal, state, and county emergency preparations. Next, please. And again, we've got a variety of resources. And there is a legal distinction between immigrants, asylum seekers, and refugees. Next, please. Okay, we're running low on time. I'd like to spin through the risk assessment in just a bit, so let's finish up this category. Individuals with non-English speaking, by far the largest group in the country is Spanish. And again, of note, 20% of the US population speaks a language other than English, but in California, it's more than double that. It's nearly half the population speaks a language other than English. Next, please. And here's the various resources. Next, please. And go on. Okay, income is another huge area of need and restriction during disasters. What's of note, 12% of the American population lives at a poverty level. Another 50% live at low income. If you combine the two, that equates to nearly 2/3 of Americans living at a low income level or less. Next, please. And the various links to resources. Next, please. Unemployment varies. In LA County, it's roughly twice the national average. And it's significantly higher for the number that are uninsured as well. Next, please. Individuals experiencing homelessness, roughly 500,000 Americans are believed to be homeless, and another 30 to 50 million live in unstable housing environments. Next, please. And again, our websites. Next. Transportation disadvantage. Surprisingly, Federal Transit Administration, identifies that approximately a third of the population depend upon their transportation needs from someone else, either public transit, friends, or private transportation. Next, please. And resources, next. Communication barriers, 14% of the nation can't read, 21% read at or below a 5th grade level. Educationally disadvantaged, nearly 10 million folks did not pass grammar school. Next, please. And next. Individuals living in rural areas, 18% of Americans live 10 miles from the nearest hospital, another 1% live 20 miles. And then there's a very, very small number of folks relative to the population that live, quote unquote, off the grid, that have virtually no access to healthcare. And here's a variety of websites. Tourists and travelers was something Cal OES added recently, and the important point there, this differs state to state, and for that matter, county to county, but basically all individuals are entitled to emergent care under EMTALA. However, once they're declared stable in the emergency room, if the foreign visitor, foreign traveler does not have medical insurance in the United States, they are entirely responsible for their medical bills, and they are not covered by Obamacare. Next, please. And the resources here. Okay, I'll try to spin through the risk assessment in 5 minutes. That way there's a good 10 minutes for questions and answers at the end. Risk assessments are commonplace now in healthcare. I've worked in this industry nearly 50 years. At one time, decisions were commonly made using a variety of methodologies. Now, particularly within the past 20 years, virtually all high-level decisions and certainly all projects are based on hard data. So risk assessments dominate the healthcare industry. They're required by CMS and Joint Commission in virtually every department, every function. And the whole goal of a risk assessment on the third bullet there is to identify specific OFIs, opportunities for improvement. Next, please. Okay, I'll go through the formula quickly. Next, please. This is a risk assessment showing how one particular AFN community or sub-community is rated. And basically, the sub-communities are on the far left-hand side. In this particular instance, we've got the end-stage renal disease patients that are facility dialysis dependent. It only represents, in the blue column, 1/10 of 1% of the total population. However, we rate their risk on a 0 to 4 scale. And in terms of their susceptibility during a disaster and the historical need for services, They are at the very high end. That's the 2 4s in the blue column. On the far right-hand side of the risk assessment is a relative risk score, roughly from 0 to 100. And that's developed by probability, the blue columns, times the difference of impact, the yellow columns, and resources, the green columns. We look at impact in terms of the length of the disaster and the resources of all those assets the hospital has, both staff, training, planning, etc. And in a cascading fashion, we evaluate. Currently, we've got about 200 different subcategories that are pertinent to Pomona Valley, and we rate them from highest to lowest. And that gives us, again, our opportunities for improvement. Some of the communities score close to 100, and they've been the focal point of all of our efforts toward improving our preparedness. And as you can see, this goes on for quite a while. So again, our goal has been to identify the top 10 most vulnerable AFN groups, meet with representatives, and address everything we can to help minimize or to mitigate the risk to those top 10 AFN communities. Okay, and I believe Steve's got one slide here on an after-action report. Let him finish this up,
Yeah.
and we'll be open to questions.
Yeah, thank you, Kevin. Yeah, I just wanted to show some of the planning that we've done with local dialysis and skilled nursing. We've done this a couple exercises now in a row where we've reached out and done planning with them and include them in an exercise to see what we can do to help them and what they can do to help us. We've also, as an outcome to that, had some of the dialysis centers. We've helped them reach out to local emergency power agencies to see what they could do to supply power to their building or service in the event of a large-scale disaster. So, you know, it's doing whatever you can to help each other. Same with the skilled nursing facilities. We've had a couple of local skilled nursing facilities adopt a lot of the planning that we've done, like our disaster barrels, as an example, and distribute them. I'm hoping now that COVID hopefully is waning that we can start a lot of these activities up again. Also, one of the very unique things that we've done is a couple of our skilled nursing facilities had adopted CERT training and created their own CERT teams. And I've actually was involved with a couple of exercises with their CERT teams, which is very interesting because they have huge experience within these skilled nursing facilities. And so huge resource. So just an example of some of the things that we've been able to do. We have a lot more to do. You know, we haven't touched every single thing. I don't think I probably will in my lifetime, but it definitely establishes priorities for you. So I just wanted to end it here, Mark, and we can open it up to questions.
Thank you very much, Steve and Kevin. That was quite remarkable, very much in depth. And for those of us that are in the business of really trying to find resources, having someone like yourself do that kind of work is just, it's invaluable. So thank you very much for all the work on that. And I think there were a couple of questions about if this presentation will be available, and it will, to all of the participants. They'll be able to see this presentation. But I think the one question that keeps coming up is, when do we all get this resource guidebook, Steve and Kevin? So is that something then that seems like will be available to the general public? What is the intent there?
The intent is to make this available for download. Right now, I'm working with the California Hospital Association and Cal OES. We're very close to being able to make this available where you'll be able to go on their website and download it. What I can do for this presentation is I will send out the final draft copy of this. I'll send it to Mark. And then Mark, maybe you and Sharon could send it out to the group and people could take a look at it. We'll just make it available to you. It'll have the guidebook. We did it in an Excel spreadsheet format because it just seemed to work better because each tab is a community. And then in addition to that, it will have instructions and a blank AFN DRA for people to use.
Just a quick question. As you know, ECA has developed a lot of resources, particularly for earthquakes, of course, for what to do during an earthquake for people with disabilities. Is there a way of a process for adding those to this too?
I think some of them already added in some of the resource. There is some earthquake information spread throughout it, Mark. We could definitely talk about if you and Sharon kind of want to work on the spreadsheet and add some information, we could definitely talk about doing something.
And it's all federal and state funded resources like you have. So I didn't see.
Yeah. Let me do this, Mark. When we're done here, I'll send you the most recent copy that I've been working with Mary Macy on. Take a look at it and then let's have a discussion of what you think you could add to it.
Great. And Sue,
Yeah,
too,
I would just add, Steve and Mark, the intent of the project is for hospitals. Essentially, it is based upon the risk assessment to identify opportunities for improvement and then in turn to enhance the level of emergency preparedness in each hospital, specifically addressing those unique AFN needs and restrictions. Toward that end, the list of websites are all those websites and organizations and agencies that we identified as being of benefit to a hospital manager. We purposely excluded websites that didn't speak to hospital needs, and we included quite a few even obscure websites that did address hospital needs. So again, it's dependent upon an understanding of the focus of this project. Again, it's for hospital managers.
Fantastic, understood. Yeah, a lot of what I'm talking about are guidance on what to do during earthquakes for staff, for patients, et cetera, and just make sure that.
Yeah, that would be helpful if there's a hospital manager in particular that would seek out references. He or she wants to enhance their earthquake preparedness and so forth for AFN communities, then that would be perfect.
Yeah, and I would offer too, Mark, I think I would offer for the ECA in your group that we could probably just add a tab to the guidebook specifically for healthcare/earthquake patient preparedness. And you could put your links and everything in there. We could offer that as a resource.
Excellent. So we'll work with Sue and the accessibility committee and coordinate that as we've done on this webinar today.
Yes,
bringing the two groups together and thank you also. Sharon, are there any other questions we haven't brought from the chat?
No, we've covered them all. Mostly just a great deal of appreciation for sharing these amazing resources.
Yeah, and just remember, everybody, when you do your survey, that if you like me, give me a 5. If you didn't like me, my name is Kevin Mashinsky. So.
So noted. Thank you, Steve. Well, I think one of these things that when I see presentations like this, and obviously from people that are very experienced and really understand a lot of the real challenges that we face in trying to think of everything, lists like this, even if we're not specifically in healthcare, oftentimes the topics you bring up or the particular groups that you're telling us, now remember this group exists, or that this ethnicity exists, or this, there's so many elements out there that are really marvelous for all of the planning. So regardless if you're planning for a healthcare center, which obviously this is centered on healthcare, but I think any kind of organization, it's a very good reminder of how diverse and how large a group it is that we really plan for when we make these plans and when we do, when we set up exercises, that there's a very large community out there that we need to make sure that we're very inclusive. So I appreciate everything that you brought up here.
Oh, thank you. Well, and I'm very lucky to be working with such a great team on this. You know, it's really is, I mean, everything that we do is going to be shared openly with everybody who'd like to get a copy. And hopefully somebody will take what we've done at some point and develop something for cities and counties. And it wouldn't be that hard, but obviously our focus is healthcare. So I'm hoping this will just grow.
That's great. That's all I have. Mark, does it come back to you now?
Well, as we've put in the chat, there is a link for this, and as Steve just mentioned, that there is a survey. And so you can click that now to from the chat or copy it to do that. It will only take a few minutes. Any questions as a follow-up, you can also email info@earthquakecountry.org. I will put this back on for a moment, just to make sure everybody gets these email addresses if you'd like to contact our presenters. So if you would like to put yours in the chat too, they can contact you. I will invite everybody to another healthcare webinar happening on August 31st. You should have, or you may have received the notice of that along with the notice for this webinar, depending on where you got it from. But you can go to earthquakecountry.org/calendar to see that. That's going to be specifically Great Shakeout drills in healthcare settings. It's a webinar that we've been doing each year the past few years, as more and more healthcare organizations across the country have been participating due to the CMS requirements for doing such drills. And that is a national webinar on August 31st. And again, go to earthquakecountry.org/calendar to learn more and to register. With that, I think we are right on time to complete. Thank you to our presenters again, also to our ASL interpreters. I really enjoyed watching Jamie interpret Steve's joke about the survey. And also to all of you who have participated and asked questions and will be using this information. Thank you for joining us today. Please do join us again on August 31st and let others know about that webinar as well. Thank you, everyone, and have a great day.